Hi, everyone, and welcome to today's webinar. We're happy to have you join us. We're happy to see you here. If you could please share where you're joining us from and your occupation in the chat, that'd be wonderful. While I introduce our center as well as our webinar speaker. So again, welcome to today's webinar, Perinatal Mood and Anxiety Disorders. And this webinar is sponsored by the Northeast and Caribbean Mental Health Technology Transfer Center. We are located at Rutgers University in New Jersey in the Department of Psychiatric Rehabilitation and Counseling Professions. My name is Kathy Rivera. I'm the project coordinator of this center, and I'll be introducing our center as well as our webinar speaker for today. As you see on your screen, the MHTTC provides training and technical assistance focused on evidence-based practices for people with serious mental health conditions, including illness management and recovery, supportive housing, support and employment, and support education. We also address the comprehensive school-based mental health services and supports, as well as online education courses, Hispanic and Latin mental health education. As a reminder, all of our services are available to you, including our resources, toolkits, online courses, training, webinars, and intensive technical assistance at no cost to you. And if you'd like to stay up to date with all of the events and practices and products that our center offers, we ask that you please sign up to receive our email communications. You may do so by scanning the QR code that you see on your screen, and I will also share a link to sign up in the chat box. Our funding comes from the Substance Abuse and Mental Health Services Administration, or SAMHSA, which requires us to evaluate our services. So we appreciate your honest, anonymous feedback about this event, and this will provide information to SAMHSA and assist us in planning future meetings and programs. So we thank you in advance for your participation and feedback. At the time of this presentation, Marian Delphin-Rittman served as Assistant Secretary for Mental Health and Substance Use at SAMHSA. The opinions expressed herein are the views of the speakers and do not reflect the official position of the Department of Health and Human Services, DHHS, or SAMHSA. No official support or endorsement of DHHS or SAMHSA for the opinions described in this presentation is intended or should be inferred. As a reminder, the MHTTC network uses affirming, respectful, and recovery-oriented language in all its activities and products. We also would like to let you know of our 988 Suicide and Crisis Lifeline. The 3-digit dialing code for the Suicide and Crisis Lifeline is now available, and 988 is not just a suicide crisis line, it is also for people experiencing suicidal, mental health, or substance use crisis of any kind of emotional distress. You can connect by calling or texting 988, or you can also chat online at 988lifeline.org. Calls, texts, or chats are responded to by a trained crisis counselor. Now let's begin our webinar. We have with us Dr. Mayanela Rodriguez Reynaldo. Dr. Rodriguez Reynaldo is a mother, certified lactation educator, and clinical psychologist certified in perinatal mental health. For the past 15 years, she has worked exclusively in the perinatal mental health field. She is a PSI volunteer coordinator in Puerto Rico as an international trainer with the organization. She works as a psychology consultant for the Puerto Rico Health Department Mother, Child, and Adolescent Section, or Title V, where she is also the member of the Fetal and Infant Mortality Review Board. She provides supportive psychotherapy for PLWHIB at the Center for Maternal Infant Studies at the University of Puerto Rico. And in 2020, she co-founded the first Center for Perinatal Mental Health in Puerto Rico that focuses on research, awareness, and service for the population. Again, I would like to welcome everyone, and now I'll turn it over to Dr. Rodriguez Reynaldo.
Thank you, Kathy, and welcome everyone. So exciting to see where everyone's coming from. Puerto Rico to Alaska to Hawaii. Trying to share right here. Love it. Okay. Just a minute. Okay, here we go. So we're going to be talking this. This is my contact information if you have any questions that come up. And we're going to be talking about perinatal mood and anxiety disorders. This is a great time to be talking about this. Last month, the month of May, is Maternal Mental Health Awareness Month. And for the first time, a maternal mental health task force actually released recommendations to Congress regarding strategies to improve maternal mental health care. Because we identify it as a crisis right now happening in the country. So very pertinent to be talking about this today. I'm going to be, this is a broad view of what perinatal mood and anxiety disorders and perinatal mental health is. I want to discuss a little bit of the prevalence of these disorders during this period, talk about some signs and symptoms, and finally leave you with resources available. So let's start with defining what perinatal mood and anxiety disorders are. When we talk about perinatal, we talk about a specific period of time from pregnancy up to 1 year postpartum. And depending on the literature and the research that you read, this may expand from conception up to 2 years postpartum. But typically, when we talk about the disorders and we talk about when the symptoms may occur, it's usually we see it from pregnancy up to 1 year, that first signs of symptoms. When we talk about mood, we are talking about depression, bipolar disorder, or psychosis. And anxiety, we usually include general anxiety, obsessive compulsive disorder, and post-traumatic stress disorders. And when we define disorders, we're talking about those symptoms and what affects our mood, our thinking, our behavior, and that it actually interferes with functioning in day-to-day life. So that's very important to understand that definition. When we usually talk about perinatal mood and anxiety disorders, we use the acronym PMADS. But as you can imagine, that could be very, feel stigmatizing for some. So we're moving away from the PMAD acronym and actually talking about perinatal mental health in general. So perinatal mental health disorders are the #1 complication of childbirth. It is more common than gestational diabetes, for example. So it is one of the #1 complication of childbirth. It is 1 in 5 women may experience a mental health condition during pregnancy or postpartum. It is usually underreported. We know that these numbers are conservative because of the stigma regarding mental health, especially in this period, but also because it does not include or may not include miscarriage or those who treat on their own or don't even go get help. For many reasons, and we're going to be talking a little bit about that. So we know that these conditions and the perinatal mental health in general is undertreated. Only 30% who screen positive for any screening on perinatal mood and anxiety disorders actually receive adequate treatment. We know that when we talk about BIPOC or Black, Indigenous persons of colors, these numbers are even higher and the risks are higher. For example, for Latinx, exhibit a higher prevalence of perinatal mental health disorders and are less likely to be identified or receive adequate mental health care. We know that with Black women, they receive counseling or medication less during those 6 months postpartum after giving birth compared to white women. And we know that a larger portion of Native American and Alaska Native women experience mental health symptoms during the perinatal period, and they receive less treatment as well. And we still need more information and are underrepresented in the literature. These perinatal mental health is so important because of the implication it has in the short and long term. We know that during pregnancy, a person with a mental health disorder that is not getting treated will probably have less antenatal care, will maybe not have the even the motivation to take their prenatal vitamins, for example, or go to their appointments. They might not have good nutritional care, because we know that when mental health, when there are mental health disorder, everything else gets impacted, right? And especially when it's not treated. So there's an increased risk of preterm births and other comorbidities. Regarding the postpartum, we know that a person who's experiencing a mental health disorder and not getting the adequate treatment will have more difficulties breastfeeding or may wean earlier. And they might have poor nutrition care practices as well during the postpartum period. We know it impacts the infant as well, because we see increased risk of mortality and of low birth rate or birth weight, and lower rates of exclusive breastfeeding, as I mentioned, and that also affects the infant. We see the impact that untreated mental health disorders during pregnancy has on children in terms of increased risk of stunting and underweight. And other difficulties in the development, as well as up to adolescence. We've seen some correlations with untreated perinatal mental health disorders and a high risk of suicide in adolescent children, or increased risk of mental illness during puberty. So we see that this is such an important topic, not only because it robs away the experience and joy maybe of pregnancy and birth to the parents, but also the impact it has on a second generation in the short and long term. Regarding maternal mortality, you may be familiar that the United States is has one of the highest rates of maternal mortality of the developed countries. And we see here that in 2021 and 2022, we've seen that those incidences have decreased some, but I really want you to pay attention to the disparities that still exist, right? With the Black community population and Hispanic populations, we still see high risks of maternal mortality. And what we know is that mental health conditions account for 22.7% of those pregnancy-related deaths. So again, that relationship with the maternal mortality and the care of our mental health during pregnancy and postpartum is very important. What are some general risk factors for perinatal mood and anxiety disorders? Number one, we want to know about the personal or family history of mental illness. We know there's a higher risk when there's a personal history, and we should be attentive to that during the pregnancy care, or even before that, during the conception period. If someone comes in with a history of mental illness, we should be talking about this and the possibility of having symptoms during pregnancy and postpartum. We know that life stressors or difficult transitions are also risk factors, the lack of support when there's previous trauma or adverse childhood experiences, where there have been complications with delivery, breastfeeding, or birth, can also increase risk of mental health disorders during this period when the infant and that relationship with the infant, when infants are of high needs, or when there's multiples in the family, also could be a high risk, as well as the history of fertility challenges or perinatal loss are also related. And one of the number one constant risk factors that we see in the literature is sleep deprivation. All new parents have difficulties getting into a sleep routine, but protecting sleep, we know, protects mental health. So we really need to be aware of this, and I'm going to be talking a little bit about it more during this hour. But remember that protecting sleep is super important to protecting mental health. We also know and need to be aware that health disparities when present, also present a risk for mental health disorders, right? Things like economic stability, housing insecurity, education, food security, our community and where we live, and our social contexts and the healthcare system all impact our mental health. And we know that throughout those intersectionalities, we have racism and discrimination that also places a risk on our mental health. And this is true too for this period, for the perinatal period. We know that there are what is called maternity deserts, and recently March of Dimes put out, or a couple of years ago, put out a statement about this, and they defined the maternity deserts as any county without a hospital or birth center offering obstetric care and without any obstetric providers. So we know that when there is a lack of access, so individuals who live in rural communities or that have less accessibility to good care may also present with maternal mental health risks. 96% of birthing aged American women live in maternal mental health professional shortage areas, and that's really high. 70% of US counties lack sufficient maternal mental health resources to attend to that mental health need. And nearly 700 counties face a high risk for maternal mental health disorders. And over 150 counties fall into what's called the maternal mental health dark zones, with both high risk and large resource gaps. So I just wanted to give you that context first to understand that the environment that we're talking about when we're talking about the perinatal period. So knowing that there are gaps in services, shortages of mental health professionals are all put us at risk of mental health disorders. I also, before talking about signs and symptoms, I want to acknowledge that becoming a parent, and it's a huge life transition for the pregnant person, but also for the partners, right? There is an anthropological word that is often used to compare this time period to the adolescent, another time period in our life where we have all these changes, which is the adolescence, and it's called matrescence. This was coined by anthropologists in the late 70s. And I think it's still very important to understand it because it's such a big transition in our lives. Our body and hormones change. Our role and identities changes when we become parents. Our relationship changes with our peers, with our partners, with our mothers, with our fathers, with whoever is our maternal roles in our families. There are cultural assumptions about motherhood and what good mothers look like or what they should be and what should be doing. And depending on the cultural expectations and the social expectations, there could be more expectations further away from our reality. Too, because sometimes it's expected to be the happiest moment in our lives or the best time in our relationship, and not necessarily that happens to everyone. So I just want to make you think a little bit and reflect on the importance of this life transition. And this is a vulnerable time in and of itself, even when there are no general risk factors in the life of these persons. Just becoming a mother, deciding to become a mother or a father, a parent, is a major life transition in and of itself. And then, having said that, we know there's also a vulnerability to the development of mental health disorders during this period. And when we talk about perinatal mental health, it's actually like an umbrella term for all these conditions that could happen during this period, including depression, anxiety and panic disorder, obsessive compulsive disorder, post-traumatic stress disorder, bipolar disorder, postpartum psychosis, perinatal substance misuse, parental suicide, and even complicated grief after perinatal loss. The two conditions that have an asterisk, that's depression and bipolar disorder, those are the only two conditions that actually have a specifier in the DSM-5 that include the specifier of peripartum onset. So actually that are recognized during this period, but we know from the literature and anecdotal conversations and the clinical experience that any of the other conditions also could present during this period. So what is normal and what is expected? So like I said, sleep deprivation for any new parent, that's to be expected. And in a typical adjustment, it might make the person tired. When there are baby blues, which is actually not a disorder, baby blues, when we talk about it, it's actually more of a physiological symptoms that may appear just from all the changes that we go through after birth. And it should be transitory. It does not require treatment. It is not a disorder. And it shouldn't last, the symptoms shouldn't last more than 2 weeks on baby blues. Right, so again, talking back to sleep deprivation, in typical adjustment, it might make you tired. In baby blues, it might make you emotional. So the parent may say, you know, it's just tears come out when I see the baby, but I'm actually happy. I don't even know why I'm crying, right? Different from postpartum depression or postpartum anxiety, where a sleep deprivation might make the person feel angry. And we see all the changes. I'm not going to go through all of them specifically for the sake of time, but we can see how with typical adjustment, we'll see that symptoms do get better with time and that we actually get into a routine. With baby blues, as I said, this is not a disorder, so symptoms are mild and transitory, and your self-esteem is not impacted. You actually feel good. It's just all hormonal changes, and it should go away by the end of the 2 weeks postpartum. But when we're talking about disorders such as postpartum depression or anxiety, the symptoms do get worse, especially if we do not get treatment. So a little bit about depression. This is some of what the prevalence that we see, from 26% up to 32%. We know that the DSM, as I said, has a peripartum onset, meaning it could symptoms may appear during pregnancy, but they do have a time frame of 4 weeks postpartum, which those of us who work in this field know that symptoms may appear, again, like I said, anytime up to a year postpartum. And usually women do not identify it maybe until the 3rd month postpartum or 6 months postpartum. So having that limit of 4 weeks is still not congruent with the literature on what we're seeing clinically. And as we know, with a major depressive disorder, you need to have at least 5 or more of these symptoms present for 2 weeks period consistently. And again, we're going to see that change in our daily functions. With perinatal anxiety, we see a prevalence of 15% up to 23%, and we're talking about generalized anxiety disorder, which actually is that excessive worry. A lot of the times that worry is about the baby. Is the baby feeding enough? Is the baby gaining weight? Why is the baby crying again? So it's that constant excessive worry. And the panic disorder is more of intense fear. And there's a lot of misinterpretation of the bodily sensations. And actually the person feels like they're dying, or that they're going crazy, or that they're having a heart attack. And a lot of the panic is related to being alone with a baby or not feeling like the self. And with panic disorder, also there's that fear of having another panic disorder, and how that really ends up being that the person can't be by themselves or can't be by themselves with a baby, or they fear that they're going to die and who's going to take care of the baby. So that's usually how it presents during this period. With perinatal OCD, obsessive compulsive disorder, we see a prevalence of 2% to 24%. And again, you see these huge gaps in prevalences and numbers, and that's because it depends on the research that you look at and the timing and the screening tools they use. But we know that perinatal obsessive compulsive disorder is pretty common during this period. Even with persons who do not have a history of OCD, they may experience it for the first time during this period, and they're usually the same. It's a lot of concerns and images about that are very distressful, that are intrusive, what are called intrusive thoughts, and thoughts that really make you feel very distressed and like, who would think this as a mother? You'll hear a mother say things like that. There are concerns and images about hurting the baby or about contamination with the bottles or with the diapers. And usually we need to do a behavior like a compulsion to get those thoughts to go away or to feel calmer. So that fear of making the wrong decisions regarding sleep, childcare, vaccination, very important. And again, with all of these, I think it's very important to keep in mind that we need to ask questions. We need to ask about intrusive thoughts. We need to ask how they're feeling, because parents are not going to necessarily come out and tell you, this is what I'm having, these scary thoughts that I'm going to hurt my baby. And that doesn't let me sleep, or I'm not feeling well. You need to, and that's why screening is so important. We need to ask about these things and educate about it as well. Another disorder that can happen during this period is birth trauma and just PTSD. When we specifically talk about birth trauma, again, the prevalence can oscillate. We can see from 4 to 45%. A traumatic childbirth experience refers to a woman's experience of interactions and or events directly related to childbirth that caused overwhelming, distressing emotions and reactions, and they can lead to short and long-term negative impact on a woman's health and well-being. So always asking about your birth story and how you perceived your birth story, because again, trauma is in the eye of the beholder, so it's very subjective, and it's important that we ask how that person, even if we know the story or we're reading how this birth went, if we're in a hospital setting, for example, we need to ask how the person perceived her birth. There's a lot of near misses where she might feel like her life is in danger or her baby's life is in danger, and it could be very traumatic. These are other traumatic events that can happen during this period, such as disrespect or abuse during childbirth, mistreatment during the childbirth, undergoing unnecessary and extensive interventions, prematurity, or the experience of NICU. We know that just having a baby and leaving your baby in the NICU could be a very traumatic experience for the parents. Perinatal loss or stillbirth could be very traumatic. During pregnancy, just not feeling well, and getting conditions such as hyperemesis gravidarum, which is just throwing up and just feeling sick the entire 9 months. Getting a diagnosis for the baby, which is not expected and could be very traumatic. And poor response to anesthesia, etc., could all be traumatic events that occur during this period. When we talk about bipolar disorder, also there is a high rate of prevalence during this period. And as we know, there's bipolar 1 and bipolar 2, bipolar 1 being with more distinct mood changes and those episodes of mania where functioning is impaired and it's more severe. And bipolar 2 being a lot of the times called the postpartum depression imposter, because if we're not asking for it, we might not see it. We need to ask what her previous, I mean, if there are mood changes that are significant, and what was her previous functioning like, and not assume that this is just a major depression that we're looking at when we're seeing her. So this can look like a person that can tell you that she is very high functioning, so high functioning that she feels she doesn't need sleep, even when offered to get some rest. She'll say, I don't need any sleep, I'm fine, I can clean during the night, or spending excessive amount of money during this period. We know that 70% of women with bipolar disorder relapse within the first 6 months postpartum. And a lot of the times they're taking off their medications during pregnancy. And it's important that we talk about this, understand that there are medications that could be used during pregnancy and postpartum. And that if the decision is not to take medication, then what are we offering her for support? Right? Psychotherapy could be very beneficial during this period, especially if there's no medication, and having a plan, a postpartum plan, if we know that we have this disorder from the get-go and starting during pregnancy. Then psychosis, which happens 1 to 2% in every 1,000 births. Psychosis is probably the most severe of all of these conditions, and it requires immediate medical attention and sometimes hospitalization. So we want to be asking every mom that we see about their history, because we know there's a higher risk when there's history in the family or a personal history of bipolar illness or psychosis. We want to ask about, do you feel like a stranger to yourself? Do you feel disconnected from loved ones? Do things that make sense to you do not make sense to others? We want to check her reality and see where she's at. There could be delusions and strange beliefs. It's important to understand that symptoms sometimes may wax and wane. And we might see her at one point very coherently talking, but we need to be very curious and attentive to her words, her mood, her behavior. And maybe get in some family members. If there's a partner, bring them in and ask them about how she's feeling, the changes they see in her after giving birth. Hallucination, hyperactivity, paranoia, rapid mood swings. Usually with psychosis, symptoms come in very quickly after birth. So within those first 2 weeks, we'll see a deterioration in her behavior. So really quickly, we'll see those. I also want to talk about postpartum mental health in men and paternal issues and partners. We usually think of the birthing person as the only person who can develop changes, but we know that partners, and especially men, are mostly where the studies have been done with men and heterogeneous heterosexual couples. 1 in 10 dads experience postpartum depression. They may experience hormonal changes as well. So again, screening men about their mental health during this period is very important, and seeing where they're at and having being conscious and aware to have them talk about their issues as well is very important. They have a higher risk of developing any symptoms when their partners also have a mental disorders. So they're like up to 50% more likely to experience depression or anxiety when the partner does have a disorder as well. And we're learning more about trauma during pregnancy and birth for parents. We know there's vicarious trauma as well as just PTSD from maybe seeing a birth or a complicated birth that they weren't ready about, and how, where do they talk about this, and with who, and what spaces or safe spaces are offered for partners to talk about their mental health regarding the perinatal period. They may manifest all these symptoms differently from birthing persons. They might be checking out, maybe spending more time at work than they do at home. They might feel burdened. They may experience sleep deprivation as well, and manifest that throughout anger and irritability and anxiety. They might feel jealous about feeling left out. They're losing their partner and they don't know what to do with the baby. They've never had maybe a role model. So they don't know what they do, or what to do. And again, the cultural and social expectations to man up or to see the dad or the partners as babysitters, and they're not. So it's important to ask them and give them the space as well. These are other experiences that also impact perinatal mental health that we need to be aware about and also screen when possible. We're talking about adverse childhood experiences. We know that interpartner violence increases during pregnancy, and can be risk factors when there's fertility challenges. It's also very important to talk about this with parents. With parents or couples who've had fertility challenges usually feel like they can't express anything but happiness after they do have a child, because that's what they've been working for and that's what they've been trying to do. So they can't really complain. They feel like they can't talk about other expectations and maybe what they feel. As I said before, the NICU experience could be very traumatic and can impact perinatal mental health. We've seen higher prevalence of depression and anxiety in parents who have their children experience NICU. When there's a history of sexual trauma, pregnancy, birth, breastfeeding, chest feeding can also be a trigger to that sexual trauma. And we need to be aware of that. Also, with breastfeeding and chest feeding, there's also something called DMER, which is dysphoric milk ejection reflex. And you can find more information about that at dmer.org. When we talk about DMER, it's actually mothers explain that they feel depressed or irritable or even disgusted when there's the milk letdown, and it may last up to minutes maybe during that letdown, and then it goes away. But it's very distressing for the breastfeeding person. And it could be confused with depression, and we need to be aware of this to do those differential diagnoses and know what the right treatment is. So any of all these also impact perinatal mental health. Eating disorders, another one that's pretty common during this period. And again, everything if you have a person with a history of eating disorders, pregnancy can be a trigger for this. And the first thing they do at the OBGYNs or your primary care physician is weight you and talk about your weight and how much you've grown, or you haven't lost that baby weight, and all those things could be triggering for the perinatal person. Okay, so what do? We need to start screening and offer support. This is an ideal time to screen. A person with an uncomplicated pregnancy has an average of 25 interactions with healthcare providers during this period. So that's a lot of interactions, maybe even more than any other time in their lives with healthcare providers. And these are excellent opportunities to screen, to educate, and to refer the person for further treatment if needed. Pregnant and postpartum individuals often interact with other non-medical community-based providers, such as doulas, childbirth educators, lactation consultants, home visitors, community health workers, and all of these can also screen for mental health disorders and educate. And the perinatal period is a perfect time and a unique opportunity to have a two-generation approach, because when we impact her health, we impact the health of this baby as well. The American College of Gynecologists and the American Academy of Pediatrics and the United States Preventive Services Task Force for Preventive Services all have made recommendations on screening and the importance of screening during pregnancy and postpartum period. These are some of the best practices, talking about screening in the first prenatal visit, at least once in the second and third trimester, during the 6-week postpartum obstetrical visits, and then repeat screening at 6 or 12 months, and during those well-checked baby visits in the pediatric setting. Ideally, when we do screening, we do it in a private setting and confidential. And, we also talk about, because just screening and giving a paper and adding up some numbers is not enough. Screening is about opening up the conversation. It's an opportunity to talk about mental health and what this transition has been for them and what they need and how you can better help them get the services the person needs. These are some screening tools that are available. Most of them are also available in Spanish. I think that's important to mention. The Edinburgh Postnatal Depression Scale is probably one of the most widely used. It's free. It's 10 items, and it's pretty self-administered, and it's pretty easy to administer, but you'll see that there are different screening tools for all the disorders that I've talked about. Ideally, doing that mood disorder questionnaire, which is for bipolar disorder with the Edinburgh, is ideal to detect bipolar 2, as I talked before. We want to, again, educate clients, and whenever there's family, bring in the family. Everyone should be informed about what perinatal mental health is and perinatal mood and anxiety disorders. Have a safe environment, normalize that conversation with your clients, avoid judgment, reduce fear of disclosure, especially for immigrant families or that may have fear to disclose their mental health. I mean, we're not going to call family services because you may be experiencing depression or anxiety. It's actually very treatable, and we need to open up that conversation and normalize it. Support the mother-baby bonding. Always be culturally sensitive and know your resources in your community. That's very important. Understand that words matter, that instead of saying you're just a new mom and everyone struggles, we can normalize and validate the feelings by saying having a baby is a life-changing event, and it is completely common to feel stressed and overwhelmed about your new life immediately after giving birth, and just commonizing this instead of normalizing. Also, but just talking about it and validating what this may feel, and that it's okay to get help. Instead of saying you're tough, you can do this if you try hard enough. We know that getting help is never a sign of weakness, and we should encourage new parents and everyone who needs it to get the help they need. Also, always when talking with families, always have that perinatal lens as a framework, and understand that we should look beyond signs and symptoms of a condition and to consider all the areas that are impacting our client during this time. Again, talking about sleep disruptions, those identity shifts, understanding that this is a huge life transition and they may not feel comfortable disclosing how they really feel, that there may be a lack of support, financial strains, those body changes, and just the entire reproductive history and what that looks like for this client. It's very important to always keep into perspective. These are some of the evidence-based and emerging practices that we know are have been successful with perinatal mental health disorders, and that's CBT, interpersonal therapy, dialectical behavioral therapy for trauma, eye movement, EMDR. Family therapy is very important, especially if there is Latinx families that we usually need to integrate everyone else in the family that's available as a resource. Group therapy and having mom groups and having moms connect with other moms is very important, as well as dads, and just that reducing that feeling of isolation during this period is very important. Mindfulness and mind-body techniques have worked. Medication, we know that work, as well as peer support. So, and sometimes the person might need peer support, medication, and individual therapy, all three. And it's okay. And we should be able to talk about that and inform our clients about that and about the alternatives that are available. So before we go into questions and answers, I want to give you some resources that are available in case you don't know about them. Postpartum Support International, that you can find in www.postpartum.net, has a lot of information and groups and support groups, as well as specific certification and training for on this subject. This tool I love, and it's in English and it's in Spanish. It's called the Perinatal Mental Health Discussion Tool. And I think it's an important way to open up again the conversation. It's not a validated screening tool, but again, it's a discussion tool. Where the parents can just, you could have it outside and the parent can just look at some of the signs and symptoms and be able to identify whatever they need to identify or ask about what they need to ask about. These are some of the support groups and information available. These are support groups in English, and these are some that are in Spanish. As you can see, PSI has weekly groups and bi-monthly groups and monthly groups in about every subject you can imagine. There are groups for queer and trans parents. There are groups for mindfulness. There are groups for laws, for fertility issues, for NICU parents. So very specific up to general, just support for moms and parents and families. If you're struggling with a parent, if you're working with a parent who is struggling, I think it's important that you know that there's the free PSI helpline. Again, that's in English and in Spanish, and they receive calls as well as text. There is a PSI directory, so we have professionals who have been certified all over the country and internationally as well. And PSI also has a perinatal psychiatric consultation line where if you are a prescriber and you're not sure if you can prescribe this, or if your client is is taking this medication and what does that mean, you can always call an expert and consult. This is a national maternal mental health hotline that is available 24/7. And it's in English and in Spanish as well. So it's a very useful resource to have and to give out to parents. And again, before we go into Q&A, I just want to remind you that when we pay attention to the beginning of the story, we can actually change the rest of the story. And I think that's, for me, that's one of the most important pieces in working with this time period and the perinatal period, is the impact we make. I mean, if we want to talk about prevention and if we want to talk about how we change the future, this is it. Because when we give these babies and this new generation a better chance with parents who actually attend to their mental health, they have a better chance of thriving. Again, it's very encouraging work, very important work. And I'm opening it up to questions now.
Thank you, Dr. Rodriguez Reinaldo. At this time, we do have a couple of questions for you that came up in the Q&A. Here's the first one. Someone asked, do adoptive parents who adopt a newborn also experience the same or similar symptoms?
Yes, that's a great question. And there is a syndrome of for adoptive parents. It's very important that we keep that in mind. They could experience all of these. And again, they get dismissed a lot of the times, or they might feel like they can't really complain or talk about it because this is what they wanted. This is what they've been fighting for. And any of you who've worked with the adoption process, we know it's a very long process. It could have a lot of challenges within it. And so yes, all of these could happen with adoptive parents as well. And I think it's very important that actually we do have, I think, a supportive group with PSI for adoptive parents, because it is very common that they experience some of these. So thank you for that question.
Yes, very interesting indeed. I also noticed the uniqueness of the question. Our next question is, working in a hospital setting, we often focus on the patient and the new baby. How do you suggest we incorporate the child's father and screen them for mental health concerns?
Great. Yeah, I think I'm glad that you're even thinking about this and how to incorporate the fathers and the partners. So usually they are around it depends on the hospital setting and who comes in, who does the screening. If you do the screening for the mom, I think it's a good time to also have the dad on the side. I mean, they're usually there. They come as visitors. They're not visitors, they're part of the family as also. So it depends on your setting and where you could do. I would do it privately so they can have that experience and that time. So whoever does the screening for the mom maybe can take some time and say, I'd like to speak to you as well. How has this experience been for you? I like to give you the screening tool. I mean, the Edinburgh is validated for both the moms and the fathers. So it's validated for the fathers as well. So you can give that, or maybe you can just give information on dad's group, and maybe within the hospital setting, you can't do that one-on-one with the dad, but you can definitely educate and give them information to take home. Listen, being a new dad, a new father, because they're actually having two roles here, being the dad and being that support, being the partner and being the support for the mom. So that might be very stressful for them. And just letting them know there are support groups for fathers. And if you ever feel like you need to talk, here's some information. So I would do that. See, I mean, whatever works for your setting. Think about those. But I think if you don't get to screen, at least educate and give them information. That's very valuable. Just having them leave with something.
Absolutely. So I have a couple of questions that came in more on what will be offered after this webinar concludes today. So everyone will receive a link to download the presenter slides in PDF format, a link to access the recording, as well as a link to the evaluation survey. Again, if you have any questions, please feel free to email us. You may do so at Northeastern Caribbean at mhtccnetwork.org. Dr. Rodriguez Reinaldo, thank you so much. We don't see any other further questions. So again, I just want to thank you for providing us such an insightful and helpful webinar on this topic and bringing more awareness to this topic. I want to thank everyone for attending and participating so actively today in our webinar. And again, if you need any further assistance, feel free to reach out to us. So again, thank you. And I hope everyone enjoys the rest of their day. Have a good one.
Kathy.